So thank you everyone for joining us today. For those of you who don't know me, my name is Emily and I'm just one of the regs involved with the SimStars committee at present. We've had lots of interest so far and have had some good feedback as well from the workshop, so hopefully it'll continue. I'm delighted today to welcome Dr. Robbie Kernan, who's a paediatrician here in University Hospital Waterford. I know he's a lot of experience in simulation-based education, spending some time in Canada, I think, training in that area. So I'll hand over to him at the moment and we'll go from there. Thanks, Robbie. I think you might be on mute.
Good start. Thank you for the introduction and thank you for inviting me to speak at this today. So just to give everyone a little bit about my background, was that I trained as a simulation. I did a fellowship in simulation medicine and pediatrics in Toronto from 2018 to 2020, and just got exposed to a lot of the teaching techniques. And the topic I've been given to today is to talk about simulation on a budget or on a shoestring. So I've prepared a few slides with that in mind, which I'm going to share with you, and see. We should have some fun with this and see if we can come up with creative ways to use our own local resources.
And just before you start there, Robbie, I might just introduce as well Dr. Marcus Kennedy, who's a consultant in respiratory physician, who's also chatting with us as well today around the same topic.
Hi, Marcus. Okay, so I'm just going to try share my screen here. Can everyone see that okay? Okay, so my topic is simulation on a shoestring. So my talk outline is as follows. So first of all, I'm going to show you what you could have by introducing you to one of the high fidelity simulators, just to ensure everyone's on the same page as to some of the features that are available. Then I'm going to progress by moving on and trying to see what we can do to keep up with HAL, or what we can do in our own environment that wouldn't be so expensive to give us the same features. Then I'm going to proceed by talking through some task trainers and alternatives to task trainers. And following that, we're going to talk about moulage, QR codes, and some non-technical simulations. Talk through what HAL is. So HAL is like an advanced simulator. So with the advanced simulators, you get a lot of additional features that you don't with the low fidelity mannequins. So in terms of realism, HAL is able to display kind of project a voice controlled by an operator remotely. He's able to control his vital signs again remotely, so someone can either go up or down with their pulse, with their respiratory rate, with their blood pressures and things, just to increase realism in the scene. Equally, then on top of that, he's got facial expressions. He has the ability to say that he's in pain. He has also the ability to display clinical signs such as delayed capillary refill time, respiratory signs such as wheezing or stridor, and equal on top of that, he can have seizures and things like that. And one of the other built-in things with HAL is that he's the ability to have procedures done on him. So it's the ability to have either, finger prick blood glucose taken, lines inserted, chest drains inserted, airway management skills. So those are all options that we're going to show through the video. So I suppose the bulk of my presentation really forms around what does HAL have that I don't? And really the question is, do I need these bells and whistles in order to complete my learning objectives? So what we're going to look at is how can I use my own available resources to increase realism while keeping in at a low cost. So I'm just going to move on to my next slide. So if I play this, can you see that slide now?
No, it hasn't moved up from the previous slide. I wonder, do you have to go out to?
I don't know.
It's moved now. Orpheus is on screen.
Yeah.
There's a bit of a delay, obviously.
Okay. So one of the things that we look at with simulations is realism. So you can see Morpheus there from the Matrix, and he describes realism is if real is what you can feel, smell, taste, and see, then real is simply electronic signals interpreted by your brain. And effectively, what we're trying to do in simulation is we're trying to create these real experiences for people. So we're trying to get them to have the same ambiances that they would have received and have the same stimuli that they would have received in the real world, and then guide them through these experiences so that they feel the same. So my next slide just runs on to how can we show the same things that HAL has. So HAL has internal voice streaming, but equally I would say that that's achievable if you have like an actor as a parent reporting as a child. So when HAL says, I'm in pain, I have a headache, I feel sick, that's easily replicable by a parent in your simulations describing something similar. Equally then looking at other things that HAL has in terms of pulses or capillary refill time, I would say a facilitator during the sessions can prompt. So for your own simulations that you're going to put into SimStars, if you don't have a facility to say his weak thready pulses or his capillary refill time is 5 seconds, that can be prompted by either a facilitator in the session or a nurse in the session. Other things that HAL has are things like blink, the ability to blink, the ability to create tears, the ability to show facial expressions and head movements. I don't think we can really create that, but my question would be, is that entirely necessary to complete your learning objectives? And more often than not, I found that these additional things, whilst they're nice in terms of realism, I don't think that they advance your ability to reach your learning objectives. Feels like being able to take peripheral glucose checks, again, in terms of task training, it's an unnecessary added benefit to him. There's no shortage of people that would offer a real finger to try the real technique. So I think it's unnecessary. And similarly, then looking at auscultation of clinical sounds. So again, I think that these can be beneficial, although not always entirely accurate. So if you're going through an asthma case and you want the participant to pick up wheeze, so you could prompt them when they listen, oh, you're hearing wheeze on both sides with good air entry. But equally than that, if you want to go one further, you can download clips of wheeze or MP4s of wheeze, and you can either play them on your iPhone beside the low fidelity mannequin, or you can go one further and you can look to conceal a speaker. So you can conceal a speaker either under a mannequin in order that they hear the sounds when they listen. So it's just all options that you have to really keep up with HAL. Other features that you would have seen in the video is that HAL comes with inbuilt CPR feedback, so that if you're doing a cardio arrest scenario, you'll get feedback as to the quality of the compressions. But equally, this is not required in that you can also purchase feedback recording devices or reasonably cheaply for kind of less than €60, and they can be either put on a BLS mannequin or beside a BLS mannequin, and that can add to realism if that's the learning objective that you're looking to achieve. HAL has the benefit to change cardiac rhythms, to go from VF, VT, SVTs. So I would say that from a low budget point of view, that takes prior planning. So prior planning would be to print off some ECGs prior to the session beginning, and you can bring those ECGs. So once they look for a rhythm check, you can give them a copy of the ECG as the rhythm check. Changing vital signs is, I think, a very useful technique, and I think it's an important realistic technique, because I think as physicians we rely on vital signs during a lot of our more acute management of cases in order to know are we going the right way or if we need to change tack. So I've been exploring a little bit as to how to do this on low budget. And the next slide, I'm going to talk about split screen monitoring and how that can be used in order to either give participants affirmation that they're going down the right track with the patient getting better during the simulations, or equally to ask to show them that things are going down the wrong track with a deteriorating patient that they might need to change their course of action on. Similar features on the high fidelity mannequin would be when they show a mannequin seizing. And again, that's not something that we can portray really with low fidelity mannequins. However, if it's an important part of your learning objective, you always have the option to download a video of a patient seizing in order to show them, in order to make sure that they're in the mindset that that is what they see once they see this patient. Or equal to that, simple prompts will also ensure that you can go down the route of controls of seizures. In terms of being able to perform procedures on the mannequin, the options, instead of having a physical mannequin to do this, is to use task trainers. And you can buy relatively inexpensive task trainers if you are looking to just solely display a task for people to become more accomplished at. And equally, there's an option at home to either make your own task trainers or to use kind of common stuff that's readily available if you want to go really on a shoestring and keep the costs down. And finally, HAL has the ability to use skin which can be cut and sutured, and equally surgical trainers or fake skin will have the same effect. Kind of always think about like what do tattoo artists and people who pierce practice on, and I mean, there has to be alternates that aren't real skin in order to make this more achievable. So just a bit more on split screen monitoring. So this is an idea that that uses two devices for connectivity. So really the instructor has a device in their hand, which is a control device, and that is linked into either a laptop or a tablet or a monitor which displays changes. And it enables the instructor to, first of all, set the changes, but it also enables the trainee to see vital signs and to respond to alarms that would go off. I think this again promotes realism for the trainees, as they're, you know, if they hear monitors going off, they're getting more used to the environment that they will be working in if there is a clinical problem. I found a few apps online to test, and some of these apps are inexpensive. The apps that we tried are the SimMon and the True Monitor apps. I think the concept of them is good, but they often fall down in terms of functionality. So sometimes they'll connect, and sometimes I was having difficulty connecting them. And sometimes the user interface is perhaps not as user-friendly as a higher fidelity mannequin. There are options then to spend slightly more on these types of split screen monitors, and the iSimulate ALSI model, it looks quite user friendly. It comes in at a startup cost of probably around 4,000, and then a yearly fee of 1,000. However, I think you get a good degree of realism from this, and if you correspond that to the cost of a high fidelity mannequin, which is starting off at maybe 60,000 for the mannequin itself, I think it gives I wouldn't say on a shoestring, but maybe more on a, don't know, satin robe or something. But it's an option if you want to turn your low fidelity mannequin into a higher fidelity simulation. So next, I'm going to talk about task trainers. So again, these are inbuilt into a high fidelity mannequin, but they don't particularly need to be. So you would have all come across high fidelity mannequins during your training sessions, probably through the resuscitation courses that you would have done. So in the top left, you've got something like a CPR trainer used in BLS skills. They come in all different shapes and sizes. There's a lumbar puncture trainer up above, an airway trainer down below, phlebotomy trainers. And I suppose these are teaching aids which encourage learners to focus on individual skills, whereas a lot of the simulations that we will look to do will actually focus on a full situation. The benefit to purchasing task trainers as opposed to high fidelity mannequins is they're an awful lot cheaper, and the parts are also replaceable. So once you do the lumbar puncture a few times, you can replace the pads on the back, and that allows you to continue performing procedures without having the initial field or already being marked. So moving on to, you can also become creative, and you can make some of these task trainers at home. So one of the I work with neonatal trainees here, and there's always a fear with new registrars about inserting in IV lines. So one of the lines we put in neonates are umbilical lines. So you have an option to purchase a task trainer for umbilical lines, but effectively what you're gaining is you're gaining a rubber tube with 3 holes in order to put in UACs and UVCs. So what we've started to do is we've started to get consent from parents to take the discarded part of the umbilicus from the placenta, the parts that would otherwise be incinerated and not used. We cut the top off an Aptamil bottle, and we use that Aptamil bottle just to give just to act as if it was like the skin around the umbilicus. And that enables trainees to actually have the realism of feel with the umbilical cord itself, and to get exposure into putting in lines into what the real vessels are. I was thinking about kind of other, so I'm obviously pediatrics based, but there are alternatives for non-pediatric based. So in terms of surgical specialties, you can spend money on task trainers for suturing, for learning suturing skills. But again, it appears unnecessary in a lot of cases. So simple things like you can open up a hospital dressing pack or a minor procedures pack and head down to the local Asian market. And what I've gone for is chicken feet in this video. Equally, these can be cut in terms of their skin with scalpels, and they can be also sutured. And it's just a cheaper alternative in order to give the same effect. So one thing I want to bring in terms of keeping costs down is the importance of reusing and recycling materials. So we all know we all had friends as interns who would open up 4 cannulas before trying to insert a cannula or trying to insert an ABG or something like that. And what I would advocate for is, if you find equipment that's been opened that is otherwise going to be discarded, it's a good idea to try develop your own simulation box if you're going to be doing a lot of teaching sessions. And the same would be if you had medications that were going out of date. These can be commandeered safely to the simulation box and kept away from other medicines on the ward and labeled as for use in simulation only. But again, trying to increase realism without increasing costs. Further task trainers, just to give an idea, would be so at the top you could spend money on a device and a thoracostomy trainer in order to insert chest strains. But really all you need is the chest strain kit available in the hospital, and you also need a way or something that gives a similar feel. So thinking about what could be a similar feel, you can get animal rib carcasses from the butcher's shop, which will give you the same feel of going through. If you really need that hiss of air to be successful, you can put a balloon underneath them. Or if you really want to pretend you're draining it like a pleural effusion, you can put a water balloon underneath. So there are options if you're creative enough to do it. I've equally seen upside down egg carton boxes used as the cardboard boxes used, because they'll give a similar pop of entry once you're through the pleural space. Which got me kind of thinking, so one of the procedures again in neonates that we do are we insert intraosseous needles. So here I've got an intraosseous gun, and I'm thinking, oh, what could I use as an intraosseous needle that avoids me spending €400 on a task trainer? So I was thinking yesterday, well, could I use, I don't know, could you use wood? Could you use, I suppose, could you head to the pet shop and find dog bones to screw into? I looked online, there are other people out there that are a lot more creative than myself. So these guys are using 3D printers in order to create tibial models. So again, you'd probably need a little bit more training or familiarity with 3D printers that I have. But what they do is that they take like an open source model online of a human skeleton, and they create the real landmarks, and they use a surface scanner and manipulate them with a computer program in order to create a 3D program. And then in order to get the texture of the bones itself, they use like a type of plastic-like material called polylactic acid. And then over the polylactic acid, they create silicone molds to replicate skin and soft tissue. And again, it's just, once you have the mold available, it becomes relatively cheap to produce multiple of these if you have access through a 3D printer. So it's just in terms of other options that are out there that people would use. In addition, you probably will have heard of things like 3D printers being used for interventional cardiology techniques, using kind of taking people's own results from CT scans and MRI scans. They can create these 3D accurate models in order to simulate the anatomy that they're going to be working on. So that's a way, if you don't want to spend a lot of money on a high fidelity trainer, you'll get a similar, probably maybe an even better replicate by using some of these other techniques. Again, I just put in a quick slide on moulage, and I'm not going to try play the video. So really what moulage is, it's a way of creating a realistic environment by encouraging people to use their visual senses as to the situation in front of them. So there are loads of YouTube videos on how to do this, and a lot of it comes from kind of Hollywood actors as to how they would, if they wanted to portray like a wound or like a scar or something like that, they use really quite a lot of either waxes or Vaselines, and once those are in place, you can color them in various colors. They use a lot of kind of reds and purples and yellows to create kind of a bruising effect. And it becomes particularly effective in like pediatric populations or your adult populations if you want to, you know, if you're thinking about a sepsis presentation and you want to bring out a meningococcal type of non-blanching rash, you can do that using some of these makeups, and also they're easily removed then afterwards. So again, a cheap makeup kit like this is relatively inexpensive, and again, it will bring in realism into your scenarios at a relatively low price. Moving slightly on then to talk about QR scanning. So again, what we're trying to do is trying to evoke senses in the teaching population as to the situation that's unfolding them in front of them. So in this day and age, most people have a portable QR scanner in that they have either an iPhone available with them. And you can purchase these codes, which will then display a clinical scenario. So they could be codes which bring you onto a short video if you wanted to show like a seizing child. In this particular case, this is a kid who's having an allergic reaction. He's got kind of swelling of the lips and angioedema of the lips, and it looks like he's got some wheals across his chest. So instead of, you have options, you could either voice prompt that this is the case, but if you wanted to, you could print out a picture of this and show it to them. But if you wanted to go one step beyond, you could purchase like a QR code and encourage people to scan it. And then it becomes more lifelike through scanning in that people can perceive that this is the situation in front of them and then act accordingly. My final slide on this is really to explore non-technical sims. So all of the kind of the simulation techniques I've described earlier on are really for either acute settings or for task trainings. But I just wanted to also advise people that that is not the only role that simulation has. So 4 slides up as to kind of common things that I've seen simulations used for, which are really around the thoughts of doing structured conversations or testing process maps. So just to give an example, a case that we often see would be an agitated patient coming into the ED, either in the adult world through dementia, through substance misuse, or through an ongoing psychiatric illness. And I suppose one of the things that we like, or that I've seen trainees do, is really ensuring that they're in a safe place initially, like in terms of room positioning and making sure that the doctor itself is not in a dangerous position. And then you can explore using verbal de-escalation techniques, or what would your indications be to proceed on to medical management with pharmaceuticals to calm patients down. I don't think high fidelity mannequins are required in this situation. What you would need is probably an actor or someone who's happy to play a distressed patient. So that could be either facilitated through projects through local acting schools, or equally you can build it into either projects for medical students with your team, for fellow colleagues to play that role for the point of learning. I would say for these more communicative sims, I would advocate for someone who's a content expert to help with the debrief. So someone who's able to and is comfortable in discussing, positive things that people did during it, and also giving tips as to what they would have done in a certain circumstance can be useful. On the upper right side, one of the techniques that people use for breaking bad news is called the spikes framework. And again, this can be easily simulated, as in you have to give bad news to effectively an actor, but I think it's better to prepare that or to get used to giving bad news before you have to do it for the first time in a real environment. So this really just, again, setting up your environment properly, making sure that you have, comfortable seating arrangements, a quiet room, tea, coffee, tissues available. Inquiring as to the perception of the patient, or what does the patient know is going on. Invite them to as to what they would like to know, and then subsequently you push on and give your knowledge about the information in small chunks to them. You then recognize emotions and develop a strategic plan to deal with the medical outcome. So you can set up simulations to practice specific frameworks like this, to give trainees the ability to practice in a simulated environment. Furthermore, how to deal with angry patients, so explaining to patients that there's been a medical error. Again, you can simulate this with colleagues using similar frameworks and content experts. And finally, I feel that you can use non-technical sims really to give you an idea as how the processes run through your hospital. So this is a typical non-medical process map on the right. But for example, we changed our procedures for how we admit COVID patients here. So you can bring a patient in as if they are COVID. You can find out where your appropriate donning and doffing equipment is. You can find out what equipment you're going to need in a room, as opposed to degowning each time coming in and out. And you can plot how will you get them to X-ray, how will you get them back from X-ray back to their ward bed. So you can use low fidelity mannequins to really run through these pathways that you'll develop for patient care through your hospital. So really, just to conclude, I mean, I really admire the high performing advanced simulators. I think they're a luxury, but I don't think they're a necessity for performing effective simulation. And I'd advocate for people to consider locally readily available everyday items as props, which will help increase realism in the teaching sessions. I think in terms of reducing costs, there's a high role for reusing, recycling medical equipment. And then finally, I would consider the use of either actors or confederates to display information during the sims, or especially to use them if you're going to have low budget, non-technical communicative simulations. Okay. And that's my take on simulation on a shoestring.
Thanks very much, Dr. Kernan. That was excellent and really thought-provoking. Some things I'd never ever thought you could use as equipment for simulation. So it'd be really interesting to see what people come up with. I might ask people to save any questions that they have till the end of the session, and I'm going to hand it over now to Dr. Marcus Kennedy.
Yep. Hi guys. So I'll start sharing my screen now. Am I sharing already? Sometimes these Macs give trouble. I have a new Mac and I've had issues, but can you see my screen already or not?
Yeah, we can see your slides there.
Perfect. Okay, that's good. I was doing a talk to Saudi Arabia when I brought this Mac, and it took me 40 minutes. The Macs are not loaded to be friendly now at the moment, with a lot of non-Mac software. So well done, Robbie. A lot of the stuff you've covered there, I'll try not cover. So the full slides are there now. Can you see those? Yeah. Can you see those full slides now? On the
We
screen?
can.
Yeah,
Yeah.
perfect. Okay.
Looks good.
So I'm just going to cover a bit about low fidelity simulation and also about concepts of simulation. Now we're switching from scenario simulation and group simulation on mannequin and ward simulation. This is focusing on now procedures, which is slightly different. So this is training in a specific procedure. So obviously let me see what's going on here. My main area of interest, I can't push on the slides for a minute, 1 second now. Bloody Max, the arrows aren't working. I hit return, no, okay.
We've all been there, Marcus, don't worry.
Sorry?
We've all been there.
Yeah, so it's not going forward on the slides. So let me see. God, you think you have it worked out, and then I'm going to stop sharing and go back in here again. So 1 second now. Stop sharing. Ay. So why is the slides not going forward? Let me see. So oh yeah, they're going forward there now, and I'm not sharing with you guys. So let me just see. This is where I need Kevin DC. Kevin, are you on the line? Maybe he's not. So I'll try that again. So you can see my screen now. I'll upload the slides. Oh yeah, they're going on there. You can see that now, yeah?
Yeah, working away.
Perfect. Okay. So a few conflicts of interest. Just I have some training grants from various companies. I would recommend you look at these, the ANASCL guidelines for simulation. There's a lot of interesting stuff there. They're available free online. We've kind of talked about simulation, what it is. So into procedures. So this, I'm going to be specifically kind of speaking about bronchoscopy procedures because that's the area of interest I have. And this shows the traditional training, so non-simulation training, time and complications when you have a trainee in the procedure versus not a trainee in the procedure. I don't know, can you see my arrow here?
Yep.
Picking the pointer. Okay, perfect. So the no trainee versus trainee, when you bring a trainee in, the procedure nearly doubles in time. The sedation you use increases, and although non-significant, the yield decreases. But more importantly, complications do increase. Now, I've summary at a glance here. I kind of covered my slide there on complications, but behind this, the complications do increase with standard training without a simulator. It's got about 2015 now. There was this publication, the New England Journal of Medicine, where in the US they pumped in funding to training. So normally Medicare spends about 10 billion per year on graduate medical education, but that's a minuscule amount of the healthcare budget, which is 3 trillion a year in the US. Medical research is 100 billion a year, and there was minimum spending on medical education and research. So the Institute of Medicine developed this transformation fund to produce a workforce capable of delivering economically sustainable healthcare, and that would improve the health of patients, populations in a changing environment. I'm just going to skip through these kind of for the sake of time. So on to low fidelity simulators. Brent mentioned some of these already. You know, you have your for bronchoscopy, you have your airway mannequin. You have other low fidelity simulators we can use. You have the 3D printed ones. Not everyone has a 3D printer, and then you just have a screen and you shove a scope into a box. What low fidelity simulators do allow usually is to use a real bronchoscope and a real forceps and a real, let's say, needle for transbronchial needle aspiration. And that gives you better tactile feedback than the high fidelity ones. You have biosimulators, which are great. So the video here is, sorry, just go back here. Let's see will this work. This is a biosimulator we developed in UCC for research. So these are plasticized pig lungs that we're inflating and deflating. So they are helpful. However, a lot of these are plasticized. So you can't biopsy them. They don't last long, of course, and you can't really bring them into the hospital. Okay, so you can't really bring in pig lungs into the hospital. You could bring them into the mortuary. I was recently looking at getting pigs in to do pleural procedures, and I could bring them in, dead pigs, into the mortuary. High fidelity simulators are great for anatomy. Fantastic. They teach you anatomy, but you don't get the tactile feedback in a lot of these, particularly for bronchoscopy and endoscopy. But anatomy, great. And they give you complications, virtual complications, so on and so forth. So a combination of both is ideal, of low fidelity and high fidelity. So this is me doing virtual bronchoscopy. A couple of years ago, I was doing an EBUS on a virtual bronchoscopy platform. You know, obviously this is a developing area. I'd love to combine this with a low fidelity simulator eventually. If you don't have this, this is the Oculus 2. I brought it for my daughter about 3 weeks ago. It's fantastic. I was being chased by dinosaurs whilst on a roller coaster last night with a gun, which is great fun. So you guys have to get one of these, 350 euros if you want to learn about virtual reality. Simulation-based training in bronchoscopy, there's been a few publications on EBUS and simulation-based training, and overall they do have better outcomes. You can't see the numbers here, but you know, better outcomes with simulation-based training. And wet laboratory versus simulator. So as we said, wet laboratory using the animal tissue gives you better tactile feedback. However, the kind of high fidelity simulators give you better anatomy. That's the bottom line. So is it all about just training on a simulator? So you kind of go to the patient, before that you go on a simulator, you learn a certain amount of skills, and then you're ready to go. Well, it's not really. The courses give you kind of oftentimes just a brief training in a procedure. However, first of all, the procedure needs to be validated, that it does actually train the person in the procedure. And validation also includes, does the training differentiate a novice for an expert? So if you have a novice and an expert going on to the simulator, are they differentiated immediately? So there are principles of validation and reliability. I'll kind of briefly go through this, but validation is the property of being true, correct, and in conformity with reality. There's lots of different types of validity. For the sake of time, we won't go through them in detail. However, there's also reliability. And is there dependability of a measurement, device, or test? Is there consistency? Does the assessment tool yield the same results when used and repeating under the same conditions? So training in a procedure should not only include one simulation session, it should include revision with multiple sessions to revise. So these are important, especially for high stakes testing. You know, if you're training people on a procedure, you need to allow it to hold up in a court of law. That also, these procedures and the simulation training will lead to a framework for continuous medical education. And it's possible in the future we may need to recertify, you know, for instance, an endoscopy on simulators, and other countries such as Australia have brought this in already. So you have to have a validated pass-fail mark, you know, on a simulator. It's not about just going in and learning the procedure for an hour on a simulator. That's not enough to train you up in a procedure. Now, the tools that we use to score you as a pass-fail mark have to be validated, and these are some of the tools in bronchoscopy that are validated to differentiate novices from experts. And ultimately, you need to kind of amalgamate all this into a training program. So the training program would include a theoretical course, followed by training on a simulator, followed then by going out to the trainees center, or having the trainee send in videos of the procedure to evaluate it properly. So I'll just skip over this for the sake of time, but this is kind of on the training what you want to see. So you want to see that the apprentices training normally, you know, using standard training that we use versus the simulator training. You want to see that there's better outcomes with simulation training. And then also you want to see a difference between the simulator training on novices and on experts, okay? So the test has to be validated, okay? And is that it? You've validated it, you've done the training on it, that's not it. So now you have to go ahead and repeat the training, and also go out to the trainees, either go out to their center and evaluate them, or you have them send back videos in. That's the proper way of doing proper simulation-based training. So this is a nice graph of competency versus the type of training. The standard trainee would be here. So they start off to just learn on the go. They increase their competency over a period of time. However, what simulation does is it brings you up the kind of the y-axis straight away. Do simulation training brings you up to a higher level. So when you go in the patient, you're far more competent and safer ultimately to do the training. They're also, I mean, trainees learn differently and they learn at different speeds. And you might have heard of this term, Kusum analysis, and these are kind of curves where you evaluate the gain of knowledge and competency in training. So this was just 5 centers, 500 procedures. The first 100 procedures for these trainees was for EBUS. They had no prior experience in EBUS, and they looked at the sensitivity of procedure as an outcome. And trainees varied. Some trainees had, progressed up as the procedures went up. Other trainees progressed more slowly. There's different learning curves, and some people just didn't learn at all. So there's different learning curves, as you know, depending on your skill set. And that's why we're going away from, for instance, if you're training in thoracentesis, you just do 50 thoracentesis in your training, you're signed off. That's not good enough. I mean, 5 thoracentesis is good enough for some people, 50 is not enough for others. So it depends on your skill set. So as we said, you've got to go into a validated training program, looking at training, repeated training, but also training in your own center. And this is a good program. This is the European Respiratory Society EBUS training program. Part 1 is theory. You got to pass that before you go into part 2, which is clinical and simulation training. You got to pass that before you go into the final part, where the supervised training in your home institution. You send back videos, and ultimately you're trained in endobronchial ultrasound. Rob mentions debriefing and pre-briefing. These are important aspects of any training. So we come in with our frames of what we think about a procedure and what we think about a device. Then you learn your actions, and you ultimately have results. And debriefing later may change your actions to give you better results, and debriefing should lead into a new frame. So you should have a new frame of mind as regards that procedure. And this is valid also not only for procedures but scenario-based training. So Alfie, we developed a low fidelity simulator here, because even the low fidelity simulators for bronchoscopy are expensive, and not everybody has a 3D printer around the world. So we just want to develop something, and other people have done this, but we want to develop something that would be cheap, and we can leave in the registrar's office, and that we could send around. So this is kind of the concept, and this looks, I know, a bit crazy, but what we have is just some standard plumbing tubes. We have the lagging for plumbing. These are kind of soft and pliable. It's on a McDonald's cup holder, because again, that's pliable and it moves. And then we got toilet rolls here, which the airways you go in moves. It's not rigid. It's got to bounce up around a bit when you push a scope against it. It's got to kind of move a little. So, and then you see Play-Doh down here. So Play-Doh is great, because if you leave it out after a period of time, it hardens. It also conducts electricity, so you can do electric cautery in Play-Doh. Now, you wouldn't do electric cautery in this box, obviously, everything would light up. This is a box from Deals. These cost about €2. They might be asbestos, I don't know, but they're great. I just drill a hole in them. And we've made a load of different types of these. Rob mentioned, the price of equipment, and that's an important thing. And I had a lot of scopes that were decommissioned from around the country. However, in bronchoscopy, we now have a single-use bronchoscope, €220, which has really opened up training for our trainees. We have a screen now in the office here in CUH, and the registrars can troubleshoot and so on and so forth. So this is just training with residents. So I've done we have a few papers in submission on EBUS, but also on standard bronchoscopy. So this is a standard bronchoscopy scoring system, the BSTAT, and we took out a few elements of this, looking at scope handling and some standard procedures. What we did was, we had 14 SHOs, 4 registrars. We were limited in numbers because we didn't want people to come from other places with COVID and so on and so forth. So we did training with them on the ALFI in endobronchial biopsy and brushing. And then we reevaluated. We did BSTAT score before training, BSTAT score after training. And this is what you want to see. So this is the resident or SHO. I have resident here because this is submitted to a US journal, but SHO pre-training. And these are scores out of 29 on the BSTAT score. This is SHO post-training, a significant difference. The registrar pre-trained, the registrar post-training. This wasn't significant. However, it's probably down to the fact we only had 4 registrars, and the total pre and post. Now, the other thing you want to see here is a differentiation between the resident or the SHO and the fellow. And we do see that pre-training, this is statistically less than the registrar, and post-training, the SHOs do catch up with the registrar. So this is just an hour's training on standard bronchoscopy procedure. As I said, this is not good enough. This has to be repeated. And if you're really training somebody up, you've got to also, you know, evaluate them in patients. So this video, if you can see it, hopefully, is that video going okay?
Yeah, we can see it.
Perfect. So this is just training some of the trainees with the single-use bronchoscopes. You can see the Play-Doh there. Then this is just a brushing. This is the endobronchial view in the lagging pipe, and you're just going to see a brush coming out here. They're just doing an endobronchial brushing. Then this is training on biopsy, same technique. You can see Alfie there. And this is just the biopsy forceps going out into the Play-Doh. I mean, this looks like a real tumor, you know. So this is just the forceps going out. So they get some tactile feedback of this. It's real devices, real scope. You don't get that with a high fidelity simulator. However, what you don't get here is anatomy, clearly. Now, we can mimic some of the anatomy, but we can also make the anatomy trickier. We can put in bumps and lumps, and that's what I found, that the rougher the inside of this is, the better. Now, this is my daughter, had this at home. She learned this in 10 seconds, how to get a bronchoscope down in through a, this is, you know, low fidelity simulator down in. So 10 seconds is all it took her, guys. So we're being out trumped. The new generation, you know, all the stuff they do, we're gone. We're old people. So I would say these courses are good for fidelity, for simulation training. Coursera is an online, if you haven't seen it, an online international, I guess, center for training. You can do, you know, I was looking at a course in artificial intelligence recently, lots of kind of education simulation stuff. The EuroSim is the European Society Simulation. I did a course with them as well. Now that's a bit more expensive, but it's good to look at training. And this is just further kind of stuff at the European ERS as regards bronchoscopy training. So that's me. So I suppose you might want to open up for questions from the two of us, I guess, or I'll unshare my screen now.
Thanks very much, Dr. Kennedy. That was actually fascinating, particularly what you've done with the Alfie trainer down in Cork. It's really, really cool. And I think both of your talks just goes to show what can be done at high quality with low fidelity. I'd just like to put any questions to the floor if anyone has any questions to Dr. Kennedy or Dr. Kernan.
I have a question, please.
Yeah, work away, Emer.
Thank you both so much for your talks. They were brilliant. I learned so much and really opened up a whole new world of sim that I wasn't aware of. I have a question. This could be for either of you, although Dr. Kennedy, I know you were speaking about the BSAT tool to evaluate some of the sim. Do you think are there tools like for evaluating people's procedures or people's performance in like sim scenarios available for a lot of different types of procedures or types of situations? Or like, would there, like, if it wasn't there, would you make up your own tool just in terms of evaluating people? I wasn't aware, say, of like tools like the BSAT where you could evaluate those sims and look at how people improved. I'm just wondering about those, or what's available out there.
Yeah, so, you know, to have a validated, like, you know, you can just set up a procedure, let's say, you know, thoracentesis, for instance, and, you know, go with how it's normally done in your hospital. And, you know, for you guys that are setting up, you know, maybe doing some work on a procedure, there are validated scores for the majority of the procedure. There is a validated way of doing things. And this comes down to the metrics of a procedure. And those validated scores should, number one, differentiate a novice from an expert. So if you assess a novice, for instance, an SHO in thoracentesis versus an expert, for instance, a respiratory physician, your scoring system should differentiate the two of them. They should be reliable and consistent. And in that, if you test the consultant over a number of different time points, you get the same result. And you're talking about really breaking down a procedure into parts. So you're talking about, you know, where you hold your hands, you know, how you hold the needle and so on and so forth. So if you, I guess, are developing for this program, you know, if you're thinking about a procedure, do look up validated scoring systems. More than likely to be available for the majority of procedures. Now, the high fidelity simulators often have their own validated scores with the simulator, and sometimes the validated scores are worth more than the high fidelity simulator, and they're all copyrighted. So you know, a high level simulator for any procedures will have, you know, metrics broken down, a validated score, and that, you know, is often worth as much as the device.
Thank you.
Just to chip in a little bit, we would have like validated scoring systems for a lot of the situational sims that we would use as well, like an agreed standard of where we want the trainees to be. So kind of examples of that would be when you run simulations as part of like an OSCE scenario, or as when we ran simulations as part of like a PALS instructor course or an ALS instructor course. You have agreed standards as a minimum that you want people to achieve. And so you can use those like agreed standards really to show that your trainees are attending the level that you would expect them to get to. And then it also gives you a good basis for feedback afterwards. If someone hasn't attained these skills, you can objectively say, well, during the procedure, this didn't happen, or during the course of the situational simulation that you were in, you didn't achieve this skill. And this was, you know, this is an area that, you know, we want you to focus on, we want you to improve on, and the next time you do the simulation, we want you to achieve this marking point.
Thanks very much. And thanks for highlighting that as well, Emer and Dr. Kennedy and Dr. Kernan, because that is kind of part, as well as doing the simulation, evaluating it, and the learners and giving feedback is an area that we're really particularly, or that we would really particularly like to emphasize, as well as being just as important as running the simulation scenario, to ensure that it is a learning process that is happening. Does anyone else have any questions? I just have one myself, actually, Dr. Kernan, about the split screen monitoring and the apps you were talking about. Is that something you pre-record and you kind of press play and run, and you have to run the simulation with it? Or is it that someone kind of, say, controls it on their phone and says, okay, now I'm going to bring up the OBS for, say, this patient at this time?
Yeah, and so I think there are different modes that you can use actually both with. So you can have like if you're using the high fidelity trainers, so if you're using the LEAP system and the SimPad system, you can have pre-recorded scenarios that the patient will deteriorate after a certain length of time, or once the initial checkpoints once the initial vitals have been set, you can pre-program it to go into stage 2 of the simulation, or stage 3 of the simulation, depending on what you want to show. And then also there are other ones that you can do on the fly. So you can be the instructor so you can have it pre-programmed depending on the stage of your session, or you can decide yourself, you know, they're not moving on to give oxygen here. I've left it sat at 85 for long enough. I'm going to go down to 75. And you can make that decision on the fly. You can increase his respiratory rate yourself. You can decrease, you know, his oxygenation yourself. In terms of the ones I mentioned, you can definitely do it on the more expensive ones, the iSimulate and the ALSI one, and probably the Dart Sim as well. You can definitely pre-program them. The True Monitor apps, again, I found that they crashed and more often than not, unfortunately, and they're not expensive, so I'm not really that surprised. Especially kind of the freer ones that we tried. They were more, you couldn't pre-program a lot of those. They were more that you could just alter the vital signs depending on how the scenario was progressing. So you effectively, both is an option. Really depends on how much you're willing to invest into it.
Okay, thanks very much. Does anyone else have any other questions at all?
For the split screen, have you found any ways of doing that are free? Like, you don't have to purchase an app, that you can just, like, is there any kind of ones available, do you know about, for kind of transmitting your phone onto a laptop screen?
Yeah, it's something that I've been really looking to try try get, and it's not something that I've found particularly available. So I've gone through a couple of things like 30-day free trials with the True Monitor, and they give you a screen for an instructor and they give you a screen for a trainee. So the idea would be you don't even need 2 laptops. You both download the app. I control the app and I can control what goes onto the phone of my trainee as long as they're linked into the same program. I just didn't think it worked very well. is the reality, and I suppose it would stand to reason that a lot of companies are, they're charging, up to 1,000 for the program in order for it to work well. That I haven't found the cheaper ones available through the App Store particularly effective. I haven't said that I don't see why there wouldn't be one that could be effective. It doesn't sound like it's something that's particularly complicated. In order to just share a screen and share some different vital signs, but I haven't found one cheaply available that works consistently well.
Thanks very much for that, Dr. Kernan and Emer. Just for the interest of time, we might leave it there. But my sincere thank you again to Dr. Kennedy and Dr. Kernan. That was really, really interesting, and I think really very helpful to all the participants. Our next workshop will be on Friday again at lunchtime, and we look forward to seeing you all there. And this recording as well will also be up on our YouTube channel either later today or tomorrow. Thank you very much.
Thank you all. Thanks for listening.
Thanks, Robbie and Marcus.